Good
How
morning.
are you?
All right, and yourself?
Oh my God, it feels like a month of Sundays, don't it? Okay, let me get rid of this. Yes, yes. Oh my God, I'm so sleepy. Let me just, I'm just gonna spill the tea right now. This other tea. I'm so sleepy. I did way, way too much last night, and I didn't go to bed till
Uh
2
oh.
o'clock, and I'm real sleepy. So my eyes look like
Uh
they're
oh.
about this big. But we had a one of my friends who is a PhD doctor had a birthday, so I attended her birthday celebration, and then one of the recreation centers here hosted a line dance Christmas party, and so I had to slide through there. So I was doing way. I drove to Columbus. I had a board meeting. I did way too
Uh
much
oh.
yesterday. Way too much. So I want to be in my covers. It's cold and raining. I missed that 80-degree weather that I had down there in Texas. And so I just want to be in my covers. But no, I'm here with you. How you doing?
I'm okay.
Good. How's everything going?
It's coming along. It's
Okay,
coming
that's
along.
good. That's good. I be worried about you. You have made the prayer list. You know that, right? You're like, Lord, give him strength. Don't let him go 10 toes down. Oh goodness. Okay. Let's get this party started. So welcome to our Saturday morning tea where we discuss health information, news, education, certification tips, entrepreneurship, um, really just anything in our space, in our profession. Um, and any questions and comments that you all have, we will discuss them. I am Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network LLC, where coding education is key. And let me just ask you, do you know what it takes to be a certified marketable medical coder? Do you? Well, before I introduce my illustrious co host, let me share with you information on a free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
All right. So, if you are interested in getting more information on the 5 steps to become a certified marketable medical coder, and you are joining us in Clubhouse, feel free to hit the link at the top of the page. If you are interested and you are joining us via YouTube, LinkedIn, and Facebook, well, friends, you can check the video description for the link. And let me just say hey to everybody. Let's see who we. Oh, let me tell you, Miss Lashanta, I believe she's not in the comments. So she commented on one of my um, posts this one of the videos this week, and she was like, "I'm gonna miss y'all because I'm gonna be in the Bahamas, ma'am. Don't do that."
Oh.
I was like, "Really, ma'am? Don't do that. Don't do that." But it's a well
Nice.
deserved trip.
Yes.
She also mentioned that she was taking either she took her instructor exam last week or she's taking it next week. But so she was like,
Okay.
lift me up for the instructor exam. And it was one other thing. But the Bahamas was the one that stuck. So she she just kept saying, I'm gonna miss y'all. I don't know what to do. I'm gonna miss y'all. Girl, you can get us in the Bahamas.
That's right.
We global. Now you may if I don't know how she's going through the Bahamas. If she's cruising, you're just gonna have to pay for that Wi-Fi package. That's all. Oh.
Yep.
But anyway, I just wanted to share that bit of news about her. So she may not be joining us. But I see we got some folks in here. Hey, Shay. I got this invite folks to join thing, I guess. I don't know. People were in here. I said,
Asha was here earlier.
yeah, I saw her. And I owe her information on somebody. I owe her information. Okay. So, yeah. So those are the things that I wanted to mention about her, that she's in the Bahamas getting it in and getting some other things. And it's just been a wonderful, wonderful week today or this week. Couple of organizations that I'm involved with, grant money just been flowing. Folks have just been getting grants left and right. I'm like, look at the
Oh,
blessings that are just
good.
dropping. Oh my goodness, they're getting all kinds of grants to do all kinds of wonderful, great work. So I'm excited. I'm excited for them.
Good.
Yes, yes. It just reinforces that things are the atmosphere is shifting and things are out here. And if you want it, it's time to go get it. Don't talk about it, be about it. Go get it. Okay. So let me introduce you. So joining me today is my co-host, Mr. Jesse, even though we've been talking. He is the registered trademark, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been an LPN for next year will be 30 years.
Wow.
In 2014, I transitioned into HIM, and in 2020, I created a company, the Coding Nurse LLC, where I help other nurses and other healthcare professionals with clinical backgrounds transition into the world of HIM.
Look at you. Look at you. That was just so professional. Wow. Look at you. I'm excited. Look, I never tell. Look, because I already date myself. Every time something comes out of my mouth, I date myself. So yeah, I never give like the whole years of toil in this profession. But thank you, Mr. Jesse. We so appreciate you being here as our co-host and helping us navigate this information that we share. So,
The only reason why I really specified the number of years is because I'm an LPN, and LPNs get no respect.
well, give sir, give
So
all
that's
the respect. Get it. Get it. Wow. Well, you're right about that. We talked about that several times because they're like, "Oh, you're a nurse," and then it's like a hierarchy for you all. It's like
hmm
they kind of look their noses down, like, "Oh, you just one of them."
hmm
You're like, but I'm one of them with mass credentials behind my name. So now what? So before we get started, if you want to join in and add to the conversation, don't be shy. If you are in Clubhouse, we just raise your hand. We'll bring you up. Um, Again, this is an opportunity if you're new to Clubhouse and never been on the stage. Here's an opportunity to see what that side looks like. We always are here to assist folks in whatever training ground we have to offer. Also, if you are on Facebook, LinkedIn, or YouTube, and you have a question, put a Q in the chat before the question, so we know that it's actually a question for us and we don't miss it. So let's get into it today. So today we're talking billing process, modifiers, and help for coding jobs. So I ran across several articles this week that piqued my um, curiosity. And then there was another thing that I think I was supposed to tell y'all that I heard. I really don't remember what it was. It was something related to the OIG. There was some low lying fruit with nursing, skilled nursing facilities, and there's some sort of medication that um, they're monitoring. They just released it. It must be on the work plan. They just released um, information, and I heard it. It was either Monday or Tuesday, but it had to be Tuesday because Monday I was on a call. It had to be Tuesday, but anyway, this particular medication is for lack of a better, a sedative for residents, and they're monitoring the usage, particularly in skilled nursing facilities that have a low employee shortage. So people were using it to kind of manage the residents when they don't have enough people there. And so there was some. So this is real low hanging fruit stuff for people if they're using this particular drug on these residents in that manner. So I was like, oh my god. When I heard it, I said, oh, it's probably gonna be a whole bunch of folks getting shut down or fined or both. But I'll look for the information because it's a very specific drug that they mentioned. And yeah, their skilled nursing facilities are back on the block. So if you or someone you know works in a skilled nursing facility or audits for skilled nursing or just are involved in skilled nursing in any way, make sure you check out the OIG work plan because they have that report. The other thing I had for you all was around this uh, the billing piece, and it was an article that was written by Mead Monger. It was in I saw it on Med City News, and he's actually talking to physicians about billing and what steps they need to do to better manage the whole revenue cycle for their offices. And at the end of the day, he basically said, uh, first of all, you didn't go to medical school to do all of this, so hire a specialist at the end of the day. um, he pretty much uh, just really had like a check flow or a checklist to remind the providers about, data, workflow, analysis, all of the things that they need to do to make sure that they are getting what they deserve as it relates to the services that they're providing. So it was like make sure to assign the proper code from the get go. Of course, you need to have some understanding of what those proper codes are for those physicians, depending on their specialty. Make sure that they know or someone knows, and if not the provider themselves, someone in the practice needs to know the payer's contractual rates. Make sure somebody is tracking each insurer's payment history on time, late, um, if there's lots of additional paperwork, are there more denials than usual? That's all part of, for me, denials management. So it's one thing to um, be on the front end and you submit the claim, electronically and even get the claim and AR and all of that. It's something totally different to go behind to determine, okay, why didn't we get this paid? Let's take a look and see if there are trends related to why we didn't get this paid. Fixing those uh, errors that may have occurred, and if it's something that's related to documentation, providing the additional training and information to the providers, et cetera, et cetera. So it's a whole other animal that happens after the fact, especially if you don't get the money. Anyway, compare collections to outstanding bills. Hold insurers accountable. Don't accept less than get to the money where the money resides. Negotiate better rates with insurers rather than seeing more patients to make up shortfall. Now that right there is where the money resides. Right there. Automate at every opportunity. A short-term investment in good software can save time, money, and hassles in the long run. Consider dedicating one staff person to these procedures and outsource when possible, if necessary, easier and affordable. So I thought this was a good segue into just some of the things to take into consideration regarding billing. Mr. Jesse, did you have any comments?
I think this author should come out with an ebook or a course, and he or she would be rich by Easter, because there are a whole lot of people who want to go into practice for themselves, but they just don't know how, and the process is just overwhelming, and there's so many things that you need to know, but you don't know who to listen to. And then it's so if they could come out with a streamlined process that would basically handhold somebody, I think it's great because there's so much that can go wrong,
Mm-hmm.
and a lot of times people don't have anybody they can call to ask. They don't even know who to call to ask,
That's
and it's
true.
just I don't I just know just from my end I've always kind of had a I've always felt for providers because you go to school because what you end up doing is really not what you went to school for.
Right, right. And I think, well, that's probably why a lot of the providers, you're seeing a shift in the atmosphere. You're seeing some providers that are like, you know what, this is way too much. I cannot. I'm out, and they go and get employed with a health system or a hospital, or or other groups of physicians where they're in an employment model, where at that point they especially I think right out of school, and I think that part is encouraged because then they don't know the hassle, the headaches, and all of the things that happen in a practice coming, that you need to know because it's you're running a business. You're literally running a business um, of services that you provide to patients. And I don't know that I know that there aren't a lot of medical schools. They're starting to provide a little bit, depending on where they are, that provide that information. Like I said, I know several years ago we used to provide to residents just a real quick overview regarding um, documentation and documentation related to revenue cycle and coding and that kind of stuff. And of course, compliance. We always had a compliance session so they understood what those laws and rules and things that can harm them were. Um, but there isn't, at least to my understanding, a real in depth um, session or a course or something that they should take before they get that degree, to know how to manage all of the things that they're going to be hit with. And I think they hear from others and then they're like, you know what? I'm not going to even fool with that. I'm going over here and be an employee. But then you have some diehards that are like, absolutely not. And then you have some that are popping back over, like, I don't know if this employee thing is what I'm cracked up to be because, you know, they are independent, providers and can do things on their own. It's just again a matter of making sure they get the appropriate resources surrounding them to assist them in that endeavor. So yeah, I thought this was good. It was really good information and good information for those not only on the providers, but definitely for the providers, but also for people who are um, billing. Because here's actually an opportunity. Here's some things he's laying it out. Your providers may not know, so be that resource for them. Be the information that they need to succeed. To help them help you. Everybody, there's a win-win in all of this, and so I thought this was a good article for both parties. All right, all right. So then the other thing, okay, so this one right here, this modifier thing, I'm like, where did this come from? Have you seen this before?
Never, not
It's
until
not
you
even in
sent
my
it to me.
CBT book. I done pulled the CBT book. I'm looking like, what? How did this slide in? What is happening? So there is a modifier FT, and this modifier um, is, I'm trying to see where it was listed. I got some additional information from the article, but it was added um to the Medicare claims processing manual. So it was updated in March, and information regarding this modifier was added to it. And I'm like, well, what, how is CMS? Well, CMS does what CMS does. So I
Right.
guess I need not ask that question. The CMS has put together this modifier FT. Um, uh, 36. I was looking for it in the actual. It's not in here. I have to go back. Anyway, they used this modifier FT to um, for evaluation and management visits in I think is it for critical care?
Yeah.
It's for critical care. So it's used for critical care visits that occur during a global surgical period, but are unrelated to the procedure, and for critical care visits on the same day as another evaluation and management visit if the critical care visit comes after. So you would add modifier FT on 99291 and 99292. So I'm looking, I'm like, I'm in my modifiers in my CPT book. I'm like, well, who knew? and they released the information last year in January, but then there was a lot of questions, probably because nobody knew, but a lot of questions from those few folks that did know, and they revised it and revised some of the information. And so I was like, just reaching out, like, okay, well, for all of those folks who are in the critical care space, were you aware? Did y'all know? Because I did, and I hate not knowing. But yeah, I said, well, here we go. And there's nothing. I don't see anything in my CPT book that gives me additional information um, on this particular modifier for critical care services that CMS has put into practice. And there's more information on it. Section in the Medicare Claims Processing Manual, section 30.6.12.7. That's where I was trying to go. But it was bringing me another section. It was bringing me something else. Maybe I didn't go further enough because I want to see it from the black and white from the source. But yeah, Mr. Jesse, did you have comments on that? Had you know?
No. Not until you sent it to me. Had no clue.
I said, well, what in the world is happening in these Medicare streets?
And I guess they would have to have it because what I've noticed is since I've been doing inpatient, a lot of people are readmitted.
Mm-hmm.
A lot, and like within the 30 days.
Mm-hmm.
And if you had a major operation, then you have 90 days. So, there's a whole lot. And sometimes they do have to have critical care services, and sometimes it's related to what they have, and sometimes it's not.
Yeah, I think it's needed because like the ones that they have that we have is primarily talking about the global period, but or the global procedure period, post-operative, uh, preoperative, all of that. And it's about procedures. This is specific to an E&M visit, particularly critical care. So, yeah,
Right.
it's definitely needed. And I mean, it's funny how you when you think about it, like, yeah, that makes sense, but why does no one know? And why is it not part of the? It's probably in my HCPCS book. Now that I think about it, maybe it's a HCPCS modifier.
Mhm.
Interesting. interesting. So I just thought I would bring that out there. I'll do some additional digging and probably put together um, a video of all the finds related to this modifier. Because I was like, well, hold up, wait a minute, is something new? Is it in my CPT book? What is going on? And lo and behold, it's not. So, and then the other thing I found was from Anne Barnaby, and she put together an article on it's looking for a coding job question mark the freight train versus the bicycle, and the chart in the article, and I'll put links to this in the description, was um, was very interesting to me. Um, and she talked about looking at or doing a comparative analysis of if you are interested in a coding position in a large hospital or an established hospital system versus a small startup private practice. And there are some similarities, but there are some differences that you would need to consider um, um, if you're going to one or the other, which I thought was very interesting. And so it's kind of she kind of separated them into kind of two different tracks, if you will. If you're looking for that work, so under the large company established hospital system, um, and she looked at a couple of things. She looked at long-term growth, benefits, and positions, duties, and pacing. So in the large company system and established hospital system column, under long-term growth, it's favorable due to large departments. With a small startup or private practice, it's also favorable, but keeping with the growth of the company. The benefits in a large company, you will have a more generous benefit package, supported by the high employee numbers. So, of course, the more people, the more things that they are able to offer and provide. In a small startup or private practice, the salary may be lowered and benefit package used to make up the difference. So you may have better benefits with a lower salary in some of those cases. And then positions, duty, and pacing in a large company, usually finite and rigid list of duties. You're only changed slightly within each position. So you get your job description and kind of, except for that, and other duties as needed. But for the most part, you're required to do, what's on your job description. Whereas in a private practice or startup, employees are often asked to work outside of the box and fill in as needed without a set of duties and responsibilities. Um, so yeah, I'll stop there. Do you have any comments or things you want to say related to that?
I did, but I'll just wait.
Okay. And then the last part. Let me get my tea ready because I felt that in my spirit right there. Then she broke down applications, hiring process, and interviews. Again, split between large company and private practice. So in a large company, they are receiving hundreds of applications per day, run through a systematic process, and the review process can take considerable time. Whereas with the private practice, it's often sent directly to the hiring manager, sometimes through email. Sometimes, it's a matter of somebody and they know somebody and they need somebody, go get it. The hiring process with a large company is also rigid. It's a very rigid process. Usually includes a phone interview and a one to two in-person interviews. Sometimes you even have group interviews. With the private practice, it can be altered to match the need to fill the position. HR may be able to shorten the process, again, based on the need. And then with the interviews in a large company, it's formal scheduling process. Sometimes it's weeks in advance, depending on what's going on and folks' schedules. And then with the private practice, it may be scheduled within the week, sometimes with just one person, the hiring manager, who then reports the information to HR. So, she really just wanted to arm folks with information, again, depending on which route you or which path you are planning to take, um, what it looks like behind the scenes. And so, because I know you hear a lot of people, I can't get in, or nobody is reaching back to me or responding to me. And she just wanted to provide some insight on what the process can look like, either from the large company perspective or the small startup private practice perspective. So, yeah. And so I wanted to bring that information to you. Oh, go ahead, Mr.
I think that it's nice, high level information, but in the streets, it's not like that.
Tell us how it is in these streets.
It's a mess. These people, I mean, there's no, like, I have to tell you a story. A couple months ago, I was contacted by this associate vice president. She contacted me on LinkedIn, said that they had a position open and I would be perfect. That's what her words, not mine, perfect for this position. Sent me a link to apply for the job and told me as soon as I applied to let her know. I applied, let her know that they scheduled an interview right away. I met with her and two other people for two other departments. So there were two positions that I could choose from. So they told me I had to pick one. So I picked one, and it was a provider education position. So the associate vice president agreed. She was like, "Oh, I think that'll be great because with your background, your experience, blah blah blah." So she said, "We're going to make." She said, "Right now the position is not remote, but we're going to make it remote. Because you live in Philadelphia, and we'll reach out by Wednesday." Well, I don't know what Wednesday she was talking about because they had never ever contacted me
You
again.
still waiting on that Wednesday?
But here's the kicker. Earlier this week, I get an email from the same company from somebody else saying that they have another position open and wanted to know if I'd be interested in another provider education
Were
position.
you the perfect candidate for this position as well?
I didn't even bother to respond.
Wow. Wow.
I mean, because I don't even have a problem if they chose somebody else, but you don't ghost people, especially
Right.
when you contact them. What's that? Listen, you interview. It was a great speaking with you, but we really, we decided to go with another candidate. We'll keep you in mind.
Courtesy.
Nothing, nothing.
Wow. That's unfortunate.
It is.
That's unfortunate. But then yeah, we have folks that in the interview process, they done made it through those hurdles, they done scheduled, and then all of a sudden they choose not to show up. I've heard several. We had our board meeting, and we were talking. Um, Folks were doing kind of like an environmental scan, and they were talking about. Had you noticed odd things happening in the coding profession? Folks interviewing people in the background, cats walking across the screen. Just it's like, really? Like, even if you are working from home, even if you're doing things remote, there's still um, virtual etiquette, if you will, that should happen. And maybe that's a conversation, another conversation as well. Do you understand office etiquette even if it's virtual? Um,
Some people don't.
it's like, I
Some
don't
people
know.
really don't.
I mean, we're in class, and folks are having animals, and they need them, and it's like, okay, all right, like they're trying to get them up the screen, and this, that, and the third. But at work in an interview, come on, y'all, you gotta do better. You gotta do better.
But but if I would expect the candidate to need some training, but not a company. Like your company doesn't need to be told you don't ghost people.
True. True. That's there. That again. You to your you chose me. You called me. I didn't seek you. Well, be like y'all chose me. What's up with that? Wow. Wow.
And I just don't know um just the whole HIM, and I just don't know what's going on because as they say, the math ain't mathing.
Mm,
And what people, and it's a whole lot of people in HIM. There's a whole lot of money being spent, but there's really nothing. I don't. I've not worked anywhere in years where I can clearly say these people have their stuff together, and it's so sad. Like I understand why our healthcare system is the way it is. I really do. And it's really, really, really a shame. And they have all these hoops you have to jump through to get these positions, and you get there, and it's like, it's almost like discovering the little man behind the curtain at Oz. Like,
oh no.
it's like people, you just like, it's like you really realize, like, okay, well, so nobody really knows what's going on. Not for real, for real. I think they it sounds good, but to a point. But then uh,
But these are these newly created positions that
no,
right. So I mean, this stuff has been going. These positions, these systems, these all of this stuff has been around for a minute. So why what's the struggle? What's the
I think because for me, everywhere like has been my struggle with CDI. Period. There's not enough emphasis put on provider education.
right?
Everybody wants to dance around the issue. And at the end of the day, it doesn't matter what you say, it's what that provider documents. And why can't you get with them to get them to to do it right the first time? Like, and this whole like copying and pasting is just ridiculous.
Oh, that
Like,
burns me to know. When I worked at a large organization and we kept telling them, y'all need to squash this, y'all need to put a halt to this. And it was like this was the incentive to assist the providers with their documentation. This is what they sold them on for the EMR. So hey, this is a quick and easy way for you to document, and look at the mess that it has created. It is, to your point, it is horrible. The volumes of stuff, unnecessarily things that are documented from encounter to encounter to encounter. For what? Just talk about what happened here and now, what you did, what you see, assess it, what you plan to do, and move on. What is all this other extra stuff that you done copied from over and over and over again from the last 30 encounters? Why? Why, sir and ma'am? Why?
and then don't even pay attention
Right,
because
because there are
I did
changes
because
and
I
conflicts.
did because I was doing an operative report. Biggest day, gastric banding. Why did this note go on to say gastric sleeve?
Oh no.
All up and through, but there's an operative report that said gastric banding. That's the only place that said gastric banding. Gastric banding is not a sleeve gastrectomy.
Mm-mm.
Two to-
Totally different procedures. Two totally different procedures.
And I'm like, that's such a that's such a waste of time. And it's like you just didn't even you didn't even care to look. You just and kept it moving.
And this is the kind of stuff we have to deal with.
Hmm.
And I'm like you. I really believe there should be a whole department or something just dedicated to provider education. Um, because they're just thrown out there to fend for themselves oftentimes until something pops up, and then it's like, oh, we need to go back and retrain, or oh, we need to go back and have a conversation. Oh, we need to go back. Be proactive. Start it at the beginning. When your people come in, when you are hiring um, these physicians or providers, um, and I can say that from the large organization perspective, I guess, because it just hit me like, well, what about the ones to start their own business? Then you, ma'am and sir, need to make sure that you understand what it is that you're doing, and the documentation that's necessary for what you're trying to be reimbursed for, and the services that you're providing. So you need to make sure that you have somebody there to help you in that endeavor. You know your part, they know their part. Y'all come together at the table and make sure that everything is everything.
But when the focus is money, you're never going to get it right when that's the focus.
Yep.
And that's what it is. Because like for instance, like where I work, like we have the CDIs and you have the coders.
Mm-hmm.
So there's oftentimes, the CDI will review the case before the coders, but you have to have the same DRG. You have
Mm-hmm.
to come to the same conclusion with the case, or if not, it's called a DRG mismatch, and you can't move on until you both decide what is going on.
Okay.
So either you agree or you just escalate it and let your supervisors make a decision. But I don't do the back and forth. It doesn't really matter to me. So I'm not I don't have an ego like that. I'm not
I
tied.
know.
So so you have to. So what happens is they will, because the coders can't query the doctors directly. We get CDI queries.
Mhm.
They will come to us with our concerns. Case in point, I had a case. The person had while they had gastric bypass, while they were having surgery, they had it said diaphragmatic defect repaired,
Mhm.
and it said repaired at the hiatus. So, but that's all it said. It didn't say whether it was congenital, didn't say whether it was a hernia, none of that. So, um, the coder suggested that she coded as congenital, and congenital would be an MCC.
Mhm.
I told her, I said, I don't agree because I don't believe that somebody 47 would wait until they're 47 to have a congenital problem repaired. Like that's how you have to think about it. Like, does that really make
Does it
sense?
make sense? Yeah.
So I said I think that it was for a hiatal hernia. That's what I think, but it's not for me to decide. So I had to write up a query and send it to the surgeon and wait to get back. But that's what I think. Now a hernia is not going to bump the. It's not going to be an MCC.
Right.
Absolutely not.
Right.
But it's not all about the DRG, but that's what they make it like
Right.
because
And it shouldn't. It should be about the quality of the documentation that you have, regardless of the reimbursement on the back end.
like when I was training, well, I'm still training. My preceptor, who's a doctor, told me that I focus too much on coding. He said you don't have to code. He said they have coders. He said your job is to figure out what the DRG is. He said, you don't have to code everything. All these codes, you just worry about what's a CC, what's an MCC, or what procedure is going to increase it, and you move on.
That's a mess. And the reason why I say that, think about and let me say hi Carmen and hi Kita. They got some lively discussion going on, and I'll add them in a minute. And I that's a mess for a couple of reasons. But the first thing that is popping into my mind is all of the work. Okay, I'm putting on my public health hat. All of the work around the social determinants of health. You don't necessarily get reimbursed for the codes for adding the codes for social determinants of health. In the back end, kind of, sort of, yes, but not adding them on the front end. And if that is the mindset that you don't need to pay attention to this, or you don't need to have these codes because it doesn't affect, it does, but it doesn't directly affect that DRG or the MCC, that's going to be a problem. We'll never be able to solve some of these issues and problems and all of the things related to health equity if that's the mindset that folks have. Yeah.
And then you think like I had another case. This woman had bypass, but she developed strictures. So every so often she has to go and have EGDs where they dilate the strictures.
Mhm.
So during one of the dilations, the doctor suspected that she had a perforation.
Mhm.
So I picked a complication code, complication during a procedure, perforation during a procedure.
Mhm.
So the my preceptor was like, well, no. He said, I don't like that code because this said during the procedure. I said, okay, but it was done during the procedure. So he said, but it wasn't found out until after the procedure was done. I said, okay, but I said there are people who have internal bleeding and they don't find out until they're in recovery and their blood pressure bottoms out and they have to take them back to the OR. And she went to the hospital the next day, but he was like, well, I don't like the code. So, and apparently neither did the coder. So I ended up, um, you know, querying the physician, and he said it was a stomach perforation. Now, when you go to stomach perforation, there's no code. So the so the coder comes up with some other something of the stomach. So he asked me, did I agree? I said, I don't care. I said, this is what I think it is. Nobody else agrees. If this is what I need to clear it up and get rid of this case, and that's what I'm going to do. And that's what I did.
So it becomes production on your end as well.
Absolutely.
Mm, mm, Lord. I just, I know it's all about the money, where the money resides. I know it's business and all of the things, but I always go back to my original roots in health information and knowing and understanding all of the components involved with the documentation and the codes that are out there. Yes, reimbursement has kind of taken its root and monopolized those things. However, there's still research that happens based on those diagnoses. There's still, and so to know, how many people. I mean, look at, and I hate to even bring it up again, but look at all the stuff, all the information that we got just out of what happened with the pandemic. I mean, you know these numbers, all of this stuff. How codes, our diagnosis codes, the procedure codes, the vaccination code. All of this information from that type of data. That is not necessarily tied to reimbursement, and it's just as important. It's just as important. Um, I just feel like things could potentially be falling through the crack because we were only focused on reimbursement and again, back to the quality of the documentation But I understand. Look, everybody got to do what they got to do to make the living they got to live. And if production is what it is, which it is, and um, these coding uh, things, somebody told me, somebody shared with me yesterday that they are actively working in her facility on an AI system that eliminates the coder actively. And I said, and she was really proud. Like, oh, this is great. This is going to be revolutionary. This is going to change the. And I was like, well, what about the coder? And she was like, well, no, they will still be necessary. They will still, again, it's that mind shift and that pivot, but because things are still tied to medical necessity, and AI can't get medical necessity. They just, see documentation and see information and spit out what they see. They can't get to the um to the depths of medical necessity. So the coder's role will still be necessary, just in a different capacity. And again, we talked about that, especially if you're going into the field. There's, you got to think deeper than, oh, let me just assign some codes to things.
Well, you really do, and you have to. That's where a coding background comes in, to know why what you can assign and what you cannot assign. Because I have, every case I do, I have suggested codes that are based off of things that they pull from documentation, and you can click on it to see where it is. For instance, like I'll see almost daily hypercholesterolemia, but when I click on the button to see what the proof is, it'll say in the past medical history, high cholesterol. Okay, no, you can't code that, but it's what comes up.
Mm,
Or like incomplete PCS codes come up.
mm,
Sometimes complete PCS codes come up that are right,
mm.
but
Wow. So before we go, because we're almost at the top of the hour, let me put, if you are, how can I say it? You don't necessarily have to be a coding educator, but if you're a coding educator, or if you are maybe a coding blogger, or you write articles, or you write content around coding, let me put you up on a little game that I peeped yesterday. So, um, if you have a KHIM accredited institution near you, or access to one, you don't even have to be near you. Um, they need preceptor sites. They need PPE sites. It's a lot because of the virtual world. Things are just, it's hard for the students to get that additional experience. And one of the things that I was told was that, um, because it's a lot of departments are actually just virtual. There are no people for them to shadow or to follow or whatever. And folks are not having strangers coming to their house. I know I would, but anyway. um, but for those of us who write content, have courses, have videos, have blogs, speaking to you, they they if you have content that you've placed out there, if you put together an assessment with your content, so you provide the information, you itemize, you tell whatever, and somewhere there is a link to an assessment for that student, and you can build these, package them to the institutions that may need PPE. Hey, I got such and such a course on blah blah blah, and there's a 10-question assessment at the end, and the instructor can't be involved with the assessment, so the assessment has to come back to you, so that it appears that there's an interaction between the person that provided the information and the student. And you can go back and say, hey, you did a great job, or here's some things you may want to look at, or whatever. But you could do it per student. So there's some entrepreneurial game for somebody to consider. So I thought I'd just spread those little gems, that little hot tea for the day. Especially if you already got stuff out there, you already got some content in the back of your mind. All you need to do is put together an assessment and reach out to some folks and say, hey, in the event that you need some additional coursework, because my understanding, what I heard, they're struggling. They're struggling to find that additional coursework, and they can't do it as the instructors in the program. It has to be external to be applicable for PPE. I see you turning. I see it.
Yeah.
I see it, sir. So I'm putting y'all up on game. Y'all know how I do. When I hear it, I'll let y'all know.
So you just basically, if you already have a course, you just create an assessment, then you contact a school that's accredited and say, I have this course available.
And it could be something small. It could be a little webinar you even did, and she kept saying an hour, but I don't know if I don't know if it's built for KM for an hour, or that part I'm not 100% sure. But she just kept saying, well, I send them to these hour webinars, or I send them to this information. But she was sitting right there. She reached out to the KM person at AHEMA to clarify about the assessment, because we were like, well, what if we get the assessment? I'm about to put y'all on more game. What if we get the assessment, have the assessment automatically graded? So you use your program, assessment is automatically graded, and the results go back to the student. That can still happen, but the results also need to come to the instructor, because the instructor, not the instructor of the school, the person who put together the content, because there has to be contact there. Without that contact, you can't. It doesn't work. So
and
go ahead.
To put some people up on more game, you could use SurveyMonkey.
Ding, 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 ding. I wasn't throwing nobody's content.
Okay.
I wasn't throwing anybody's program, but there you go. Ding, ding, ding. Automatically, it's you got a link in your thing right there. Hey, I'm even going back considering some of the things that I've done. Hey, here's all I got to do is create an assessment. Here's a link. Boom. Here you go. It's a win-win.
Yeah.
It's a win-win. So a win-win is a couple ways. Win-win. Say you're trying to build your network. Say you're trying to build your channel. You got your YouTube content out there. Tap an assessment. And if you're doing YouTube, they have some additional. I'm doing a whole bunch of games still. They have these additional components where they're pushing educational content. So if you dig deeper into where you put the information, like your description and all of that, you can actually make it. There are check boxes that you can use to make it rise to the top. So, yes. So that interaction with the student comes in with having the conversation about that. Keep it missing. Yeah, there has to be an interaction. Having that contact about their assessment and walking them through. So yeah, that was a little game I thought I'd put y'all up on. Look, I saw your board. You was like ding ding ding. I was like, I see it all over your face. I see it all over your face.
Thank you. Yes.
And I mean, there's so many of them out there that are struggling and having this thank you, Molly. Thank you. So many schools and institutions that are out there having this problem. That why not tap into the folks? So you're welcome.
Definitely.
You're welcome. And you heard it here first.
Absolutely.
Where we spill the tea. I told you we talk about everything over here. We talk about everything. Cool. So any other things you wanted to bring to the good of the room?
No, that's it. Look, you really bought it today.
to help everybody. Everybody. It was a good week. Like I said, folks got their money, and it's been a good week. I'm almost at the end of this program, Lord. I got my internship. I got my practicum approved. I got to get into my culminating experience courses. We see the end at the end of the tunnel. I'm looking at a spring graduation. I'm like, come on, y'all. I see it.
Good.
So yeah, it's been a good week.
But this kind of information is helpful because I truly believe the only way out of this is entrepreneurship.
Amen.
Because these people are not trying to change, and you cannot. How long can you fight the same fight?
Yeah. Mm-mm-mm. Well, we are at the top of the hour. Thank you again for joining the Saturday morning tea. Mr. Jesse, did you have any closing thoughts?
No, I enjoyed it. I thank you every week for creating this space because there aren't people out here who are telling the truth like us. They really aren't.
And to give you some different perspective, it's like you can get the textbook perspective. You can get the I don't know. You can get the pie in the sky, rose colored glasses perspective, or you can get the tea. I think we provided the tea. So if this information was valuable for you, help us share this message. Share the video. My understanding, I learned something else. Sharing is caring. Sharing the video with others, even if you just put a link on your page so other people can see it, actually helps spread the message. So liking it is wonderful and great. We appreciate that. Even subscribing is fabulous. We appreciate that. But sharing is where the money resides. And sharing is where other folks get to put their eyes on it. So you share, then they share. It's like a pyramid scheme. Keep sharing. But you can also subscribe if you want to be notified of when we have our lives. And don't forget to check out Mr. Jesse's The Coding Nurse channel on YouTube as well. There is some wonderful content that I already see in his head. He's gonna be repurposing and adding some some evaluations too. But again, last but not least, in my Clubhouse, to the people there, don't forget to click on the green club where you can join in on the fun in our club. Nobody came up to the mic though today. I don't understand. Y'all was quiet today. Quiet. But you will also get notified of our live broadcast, and we are here on Saturday mornings from 9 to about 10ish Eastern Standard Time. Yeah. Did you have a good holiday?
Yes, I did.
Good. Stay on a little bit because I do have some private hot tea for you.
Okay.
That I mentioned. So we'll dish that one out too. So this has been great. Thank you all for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care.
Bye-bye.
Bye.